65-year-old man who presents to emergency department with complaints of vomiting of bright red blood. He also gives history of chronic alcohol abuse and similar history of vomiting in the past. On eliciting past history, he confirms that he is also passing black stools since the last 3 days. While examining, he again vomits large amount of blood. He has become more drowsy and his vitals are deteriorating with a heart rate of 145 per minute, blood pressure very low, 80/54 millimeter of mercury, respiratory rate 35 per minute, and saturation 92% on nasal prongs. So, how do you proceed from here? So, what's the answer? The patient is having massive upper GI bleeding, which would require urgent stabilization. Assessment of airway status, because patient may require semi-urgent intubation, and a biggest risk over here is aspiration, and you need to optimize the circulation. So how will you treat the circulatory collapse in this patient? Immediately insert 2 large bore peripheral IV cannula, 14 or 16G. Central venous access is not needed immediately, but lab investigations should be sent as urgently as much as possible. You insert the cannula, send for the labs. Start normal saline or ringer-lactate boluses and try to control the bleeding and consult a gastroenterologist. So what are the investigations that you would like to send? Complete hemogram, renal and liver function tests, coagulation studies, blood grouping with cross-matching, ABG to assess for the lactate levels, fibrinogen and TEG, that is thromboelastogram. So what orders will you give to the blood bank? Arrange PRBC, FFP and platelets, because as you know, in such a case of GI bleed, you might require to do a massive blood transfusion wherein you would need to provide the patient with blood products in 1:1:1 ratios. May also be asked to release blood without cross-matching as part of life-saving management in massive bleed with very severe hemodynamic compromise. So what can be the cause of GI bleed here? As we know, acute GI bleed, it's a potentially life-threatening abdominal emergency that remains a common cause of hospitalization. Upper GI bleeding is defined as bleeding derived from a source proximal to the ligament of Treves. It can be categorized as either variceal or non-variceal. Variceal bleed, it's a complication of end-stage liver disease, while non-variceal bleeding is associated with peptic ulcer disease or other causes of upper GI bleed. Upper GI bleed is 4 times as common as bleeding from lower GI tract, with a very high incidence in male patients. So what are the causes? There can be esophageal causes like esophageal varices, esophagitis, esophageal cancer, ulcers, or Mallory-Weiss tear. Gastric causes can be gastric ulcer, gastric cancer, gastritis, gastric varices, 𝑑 lesions. Duodenal causes might be duodenal ulcer, vascular malformations, including aortoenteric fistulae, hematobilia or bleeding from the biliary tree, hemosuccus pancreaticus or bleeding from the pancreatic duct, severe superior mesenteric artery syndrome. So, if you consider the gastric anatomy in this fashion, you can find out the lesions and the common sites affected by these lesions, which leads to massive GI bleeding. So herein there are the esophageal varices, lower esophageal varices, gastric varices, Mallory-Weiss syndrome occurring from terrible retching, vomiting, and tearing in the gastric mucosa. Drugs are like NSAIDs, alcohol, then ecosprin, they may cause reflux esophagitis. Here are the sites of gastric ulcers, duodenal ulcers, then hemorrhagic gastropathy and erosions. One of very common cause of hemorrhagic gastropathy is uremia, gastric CAs. Okay. Other uncommon causes might be hereditary telangiectasia, that is Osler-Weber-Endo syndrome, pseudoxanthoma elasticum, blood dyscrasias, 𝑑𝒓𝒆 gastric vascular abnormality, portal gastropathy, graft surgery with fistula. So this was the ligament of Treves about which we were talking. Any bleed above this, upper GI bleed, bleed below this is lower GI bleed. So etiology we have already discussed. So upper GI bleed, 1 to 2% of the cases might be due to watermelon stomach. What is watermelon stomach? Gastric antral vascular ectasias, which we often observe in chronic kidney disease patients. So what is the clinical presentation of GI bleeding? It can be hematemesis, that is vomiting of fresh or old blood. It occurs proximal to the ligament of treats. If it's bright red blood, significant bleeding. Coffee ground emesis, no active bleeding. May present as melena, that is passage of black and foul smelling stools. Usually the source is upper GI, but sometimes it may be from right side of the colon. Hematochezia, this occurs if brisk and significant, then the cause is primarily upper GI. Hematochezia can be defined as the passage of bright red blood from rectum. Occult bleeding, when the bleeding is not apparent to patient, but this occult bleeding could lead to dyspnea, then even myocardial infarction. Now, how do you differentiate between upper GI and lower GI bleeding? As we have discussed upper GI bleeding, the site is above the ligament of treats. Presentation primarily as hematemesis or melena. You will get blood in nasogastric aspiration. Bowel sounds are hyperactive and 1-creat ratio is increased. Whereas in lower GI bleed, this bleed occurs primarily below the ligament of treats. Main presentation is hematochezia. Usually nasogastric aspirate is clear fluid in nature. Bowel sounds and 1-creat ratio are normal in case of lower GI bleed. So to summarize, the signs and symptoms of GI bleed can be varied. Hematemesis, melena, hematochezia, syncope, dyspepsia, epigastric pain, heartburn, diffuse abdominal pain, dysphagia, weight loss. So, what histories are important? Medication history like non-steroidal anti-inflammatory drugs, antiplatelet, anticoagulants, iron supplements, past medical history of varices or portal hypertensive gastropathy in a patient with a history of liver disease or alcohol abuse, aortoenteric fistula, where there is a history of abdominal aortic aneurysm or an aortic graft placement, angiodysplasia, history of renal disease, aortic stenosis, or hereditary hemorrhagic telangiectasias, peptic ulcer disease, history of Helicobacter pylori, NSAID use, or smoking. Malignancy, history of smoking, alcohol abuse, or Helicobacter pylori infection. Marginal ulcers at anastomotic site in a patient with gastroenteric anastomosis. History of comorbid illness, like coronary artery disease or pulmonary disease patients with GI bleed, they are very susceptible to hypoxia. So we were discussing about the history. So history of comorbid illness is also very important while we deal with a patient of GI bleed, right? Like coronary artery disease or pulmonary diseased patients, they are very susceptible to develop hypoxia. Renal disease, heart failure patients are very prone to develop fluid overload. And in GI bleed patients, we expect and we need to give very high amount of fluids. So we have to be very careful about those patients, like the patients having chronic kidney disease or coronary artery disease. If any patient has got any coagulopathy, thrombocytopenia, or significant hepatic dysfunction, then it might be very difficult to control the bleeding. And we may need to arrange some other blood products like prothrombin complex concentrates. Then we might also have to get preparations for procuring the Novo-7 or activated factor 7, etc. These patients might develop or go into disseminated intravascular coagulation. Dementia or the patients having hepatic encephalopathy, they are very prone to develop aspiration pneumonias. Next slide. Coming to the clinical examination of these patients, okay? So clinical examination, what do we need to look for? The build and nourishment, whether the patient is cachectic or moderate or averagely built. Pallor. Pallor gives an evidence of chronic bleeding. Icterus, particularly, which shows that the patient might be a patient of chronic liver disease. Cyanosis, clubbing, lymphadenopathy. Lymphadenopathy, as you all know, that is the varicose lymph node or the left-sided supraclavicular lymph node, if present, is a very significant pointer towards the fact that the patient might be suffering from carcinoma of stomach, and also as well edema. Why is edema important? Because in patients with GI bleed, we have to give extra fluid, excess amount of blood, and if edema is present, then it might be problematic in assessing the patient clinically, whether the patient is fluid overloaded or the patient needs to be replenished with blood products and fluids as well. Now, coming to the assessment of the vitals, we need to assess pulse, blood pressure, respiratory rate, temperature, and any features of hemodynamic instability, like hypotension, tachycardia, or postural changes in blood pressure and the heart rate. And one need to also look for any source of bleeding from the oral cavity. Next slide, please, Fatma. Any source of bleeding from the oral cavity, telangiectasias in the skin, conjunctiva, oral cavity, perioral or diffuse pigmentation, paraneoplastic syndromes, and any stigmata of CLD. So in the next slide, I would be describing the typical features of stigmata of CLD that gives us an indication that the patient might be suffering from a chronic liver disease and he had developed a hepatic encephalopathy, and followed by that he had developed a GI bleeding. So we need to be very, very suspicious that he might be suffering from gastroesophageal varices. So this is the picture. As you can see in the hands, there are features of clubbing, Dupuytren's contracture, leukonychia, bruising, flapping tremors. In the face, evidence of jaundice, spider nevi, parotid swelling, xanthelasma and jaundiced sclera in a patient with chronic cholestasis, loss of body hair, gynecomastia, spider nevi in the upper part of the torso. Abdomen might be distended. There might be some visible scars, veins, that is dilated abdominal wall veins or caput medici. There can be evidence of testicular atrophy. In palpation, percussion, and auscultation of abdomen, one might get hepatosplenomegaly, ascites, palpable gallbladder, hepatic bruit, tumors. In the legs, you get bruising and edema. Obviously, from the general observation of the patient might be a little bit unkempt. Smell of alcohol might come, or there may be evidence of Peter hepaticus. Features of encephalopathy, where there is evidence of sundowning, then disorientation to time, place, and person, altered sensorium, evidence of weight loss, scratch marks from itching. So what is spider nevi? These are small telangiectated superficial blood vessels with a central feeding vessel. What is leukonychia? Expansion of the paler half moon at the base of the nail. Palmar erythema is seen on the thinner and hypothinner eminences, often with a blotchy appearance. Scratch marks are particularly observed in case of cholestatic liver disease. Next slide. Due to excess estrogens, you may be getting gynecomastia, testicular atrophy, loss of axillary and pubic hair, and telangiectasias. Hepatic fetor or fetor hepaticus is a characteristic sweet-smelling breath, and the parotid swelling mentioned is particularly observed in alcohol-related liver disease. So what are the risk factors for variceal upper GI bleed? Cirrhosis with hepatic venous pressure gradient more than 12 mm mercury, Child-Pugh class C cirrhosis. And so how can we diagnose these varices? Obviously, by esophagogastroduodenoscopy, endoscopy in the colloquial term is the modality of choice. Varices can be divided as small, that is less than 5 mm, or large varices, that is more than 5 mm varices. Okay. How do you risk stratify these patients? That is, You identify the patients at very high risk for adverse outcomes. And this will actually help in determining the disposition of the patient. Where you need to shift the patient, either to the ICU or outdoor, or you need to treat the patient in the wards. And this may also help in guiding the appropriate timing for the endoscopy. Next slide, Padma. Slide after that. What are the goals of evaluation of these patients? You need to assess the severity of the bleeding, the site of bleeding, and also assess for the factors that may affect subsequent management. Next slide. So, how do you assess the blood loss? If there is around 500 ml blood loss, usually no systemic signs are observed, except in elderly and anemic patients. Around 1 liter blood loss, that is 20% reduction in blood volume, would lead to tachycardia, orthostatic hypotension, syncope, lightheadedness, nausea, sweating, excessive thirst. Around 2 liters of blood loss, when there is 40% reduction in the blood volume, profound shock and possibly death might occur. So, how do you initially assess the patient? Always remember to assess ABC, that is airway, breathing, circulation, and assess the degree of hypovolemic shock. Okay, this shock can be class 1, 2, 3, and 4. So, blood loss 750 ml, class 1, 750 to 1.5 liters, class 2, 1.5 to 2 liter, class 3. Class 4, more than 2 liters blood loss. So, in class 1 shock, what do you get? Less than 15% loss in blood volume. Here, heart rate is less than 100. No change in systolic blood pressure. Urine output is fairly maintained more than 30 ml per hour. And the patient is in an alert mental state. Class 2, where there is 15 to 30% reduction in blood volume. Heart rate obviously is more than 100. The patient is having tachycardia. With orthostatic hypotension, urine output reduces at about 20 to 30 ml per hour, and the patient starts becoming altered sensorium, like he becomes anxious now. Class 3 of shock, 30 to 40% blood volume loss is observed, and also more than 120 is the heart rate. Blood pressure definitely becomes reduced. Urine output reduces further to 10 to 20 ml per hour, and the patient may become aggressive or may become drowsy. And in class 4, where there is more than 2 liters of blood loss and around 40% of loss in blood volume, heart rate is severely raised, more than 140 per minute, blood pressure is very low, evidence of supine hypotension is also there, urine output drops to less than 10 ml per hour, and the patient becomes confused. At end stages, he may also become unconscious as well. So, for the risk stratification of these patients in upper GI bleeding, there are certain scores which have been formed. One amongst that is Rockall score. Next slide, please. Rockall score usually predicts the severity of the GI bleed. Final score is between 0 to 11. If the score is less than 3, good prognosis. More than 6, there is an indication for surgery. More than 8 is a very high risk for mortality. So, coming to the next slide, where you would be seeing the factors which determine the Rockall score: age, shock, comorbidity, diagnosis after endoscopy, and the endoscopic evidence of bleeding. So, each of these categories can be scored as 0, 1, 2, and 3. So, score 0, age less than 60. 60 to 80, score is 1. More than 80, score of 2. No shock, score 0. Pulse more than 100, 1. SBP less than 100, 2. No major comorbidity, score is 0. Congestive cardiac failure, ischemic heart disease, score is 1. Renal liver failure, score is 2. Metastatic CA, score is 3. Mallory-Weiss tear or normal endoscopic finding, score is 0. All other diagnosis, score is 1. Only GI malignancy, score is 2. No evidence of endoscopic Bleeding found, score is 0. Blood in stomach, 1. Adherent clot, visible or spurting vessel, score is 2. There is another score which is known as the AIMS 65 score. Next slide, Padma. It's a simple risk score that predicts the in-hospital mortality, length of hospital stay, as well as cost in patients with acute upper GI bleeding.